right, we are going to get back to our program this morning. And I have the pleasure of introducing Dr. Spiro. He is an assistant professor of radiology and is a staff neuroradiologist here at the University of Pittsburgh for the last 4 years. And so with that, I will hand the program off to Dr. Spiro. Thanks so much for being with us.
Thank you. Hi, good morning. This morning we will be speaking about neuroimaging in pregnancy. And I have nothing to disclose. So multiple physiologic changes during pregnancy can exacerbate pre-existing neurologic conditions or cause the onset of new neurologic disorders. Neuroimaging may be necessary to differentiate between acute disorders that require immediate intervention and those that are chronic or benign. Confusion about the safety of these modalities for pregnant women and their infants can result in unnecessary avoidance of a useful diagnostic test. Choosing the most appropriate diagnostic neuroimaging study involves pre-test likelihood of serious treatable disease, diagnostic utility of available modalities, and the risks of each modality. Now, when imaging with CT, we have to understand the risks of ionizing radiation. Thank you. Deterministic effects are those associated with a specific threshold values of exposure. Above that level, you can have the deterministic effect. Below that level, that effect does not occur. This may include organ malformations and neurologic effects in the fetus, and it could only really be achieved with multiple CTs during a signal pregnancy. Stochastic effects occur without any defined threshold and are believed to occur at any level of radiation. And this includes the development of childhood malignancies, including leukemia. Dose-dependent risk for leukemia has been estimated about 6% per 100 rad or 1 gray in utero, and 10 to 20 milligray fetal exposure may increase the risk of leukemia by a factor of 1.5 to 2 over a background rate of 1 in 3,000. As such, any time that we use ionizing radiation, we attempt to use the least amount of radiation possible, as low as reasonably achievable, ALARA, to get good diagnostic quality imaging. Now, a summary was put out by the American College of Radiology and Society of Pediatric Radiology practice parameter for imaging pregnant or potentially pregnant adolescents and women with ionizing radiation. And here's a table of the suspected in utero induced deterministic radiation effects. And what they came out and said was that under a dose of 50 milligray, there is no deterministic effect, no matter what stage of pregnancy. They said, however, that the greatest potential for deterministic effect can occur between the 9th to 15th week of conception age. And with a very high dose of over 100 milligray, you can start seeing the risk of diminished IQ or mental retardation, which increases in frequency and severity with increased dose. At other stages of pregnancy, such as the first and second week, it's what we describe as an all or none. If there's a very high dose, this would lead to a spontaneous abortion. If nothing occurs, there is no other deterministic effect. And between the 3rd and 8th week, we can also see possibility of malformations with very high doses with increased likelihood as the dose increases. However, today we're discussing neuroimaging. Head and neck CT has a very low fetal exposure of radiation. Our CTs are collimated. They focus mostly just on the head and neck, and as such, the fetal dose for a head and neck CT would be about 1,000th to 100th of a milligray. So the dose is quite low. Now, as opposed to imaging with CT and the use of ionizing radiation, MRI does not have any ionizing radiation. However, potential effects with MRI include that the static magnetic field is about 30 to 60,000 times that of Earth. Pulse radio frequency can be associated with increased heat, potentially increased heating of the fetal tissue, and varying gradient echo electromagnetic fields associated with increased noise. However, the data has shown that there's been no teratogenic effects, no neonatal death or neoplasm associated with a fetus undergoing MRI. The increase in temperature has shown to be quite low, no more than 0.5 degree Celsius, and there are no documented acoustic injuries. As such, the American College of Radiology concludes no special consideration for the first versus any other trimester in pregnancy for a pregnant patient to undergo MRI if needed. Now, regarding administration of intravenous contrast, so there aren't really studies that understand the effect of whether it's ionated contrast for CT or gadolinium-based contrast on any human embryo or fetus. However, it is known that ionated contrast has been shown to cross the placenta and enter the fetus in measurable quantities. In vivo tests in animals have shown no evidence of either a mutagenic or teratogenic effect with low osmolality contrast medium. But there are still no studies that have looked for teratogenic effects on these medium pregnant women. Now, in the past, there were some rare reported cases of neonatal hypothyroidism after exposure to a lipid-soluble iodinated contrast during pregnancy. However, there have been no known cases of neonatal hypothyroidism or adverse effects in the setting of maternal intravascular injection of water-soluble iodinated contrast agents. As such, the recommendations from the American College of Radiology is that since there's no available data that shows any potential harm to the fetus for water-soluble iodinated contrast, no routine screening for pregnancy is needed before administering contrast per CT. And most of these contrast agents are classified as category B. And no extra attention needs to be given to the newborn that was exposed to iodinated contrast in the fetus because we're already checking their TSH levels routinely at birth. However, the American College of Obstetricians and Gynecologists still states that contrast should only be used if absolutely necessary because there are no well-controlled studies evaluating these effects. Now, MRI is a different story. So we know that gadolinium-based contrast has been shown to cross the placenta in primates and appear within the fetal bladder. Now, free gadolinium is toxic, and therefore it's only administered in a chelated form. Animal studies have shown that gadolinium-based contrast agents have been teratogenic at high doses, and this is presumed to be because this allows for the gadolinium to dissociate from the chelation agent. Our main concern in humans is that we don't know how long the gadolinium stays within the amniotic fluid. The concern is that the greater the time it stays in the fluid, the greater potential for it to dissociate from the chelation agent and cause risk of harm to the fetus. However, there have been no known adverse effects to the human fetus reported, and there's no known cases of nephrogenic systemic fibrosis, but there may be potential. A limited study of a Canadian provincial database demonstrated that there was an increased risk in the child of a broad set of rheumatological inflammatory infiltrative conditions with first trimester exposure to the gadolinium-based contrast agent. Also, the same review showed that there was an increased risk of stillbirth or neonatal death for the fetus that was exposed to this contrast at any time in pregnancy. However, the study has been called into question by multiple limitations. The first limitation is that the control group did not undergo MRI, and we don't have a good baseline to compare. Secondly, the incidence of children with rheumatological, inflammatory, or infiltrative conditions in this study was actually quite high in the unexposed group, and it's unclear if they also had some exposure later. Also, the risk of stillbirth or neonatal death incidence was quite low, so we don't have good data on this. However, due to the potential effects, we should only administer gadolinium-based contrast agents to pregnant or potentially pregnant patients with caution, and only if their usage is critical. And how should we define that? So firstly, the information requested from MRI cannot be acquired without the use of IV contrast or another imaging modality. The information needed affects the care of the patient and or the fetus during the pregnancy, and the referring physician is of the opinion that this study cannot wait until after the patient is no longer pregnant. Okay. Now, as we'll be discussing today, there's a whole slew of pathologies that can affect the neuroaxis during pregnancy. And I've sort of done this grouping into vascular, parenchymal, pituitary and paracellular, and back pain and spine, and I'll be focusing on the first three groups. Vascular. Now, the detection of venous thrombosis can be performed by using multiple different modalities. Now, a non-contrast CT, which was performed in the setting of an acute neurologic deficit where there was concern for ischemic or hemorrhagic stroke, may demonstrate a hyperdense thrombus, which is indicative of clot. However, pitfalls to this imaging modality is that there are other things that can cause hyperdensity within the sinus, such as an elevated hematocrit or dehydration. So this is not a very good exam for this and not recommended for first-line detection of venous thrombosis. MRI brain and MR venography head is what we prefer. However, it should be utilized when the presentation is less severe. MRI takes time and may not be readily available, but it does demonstrate improved visualization of cerebral veins and the dural venous sinuses. On MR venography, we'll be looking for loss of flow-related signal to indicate thrombus. And on our MRI, we can use multiple different sequences to actually demonstrate slow flow and or clot within the sinuses as well. There are pitfalls, though. It does take time in the scanner if the patient's not stable, and there are times that you can have flow, you can have thrombus, which is mimicked by actual flow, and you have a false negative. For CT phenography, it can offer a rapid diagnosis of venous thrombosis. However, it does involve ionizing radiation and ionizing contrast. What we would see on CT venography is a filling defect caused by clot, so to speak, our empty delta sign. So here we see how we have a patient who underwent a non-contrast CT in the emergent setting, and we see hyperdensity within the superior sagittal sinus. Although not specific, however, CT venography confirms that there's a filling defect compatible with a clot. On MRI in a patient, a 24-year-old with severe headaches and tonic-clonic seizures. So this is our sagittal T1 weighted image, and we see intrinsic T1 hyperintensity throughout the superior sagittal sinus, and that's compatible with loss of flow and clot. And we can see this nicely demonstrated on our MR-venography. So we see here, this is our straight sinus and our internal cerebral veins demonstrating flow-related signal. Now we see that it is absent on the MRV, and we see on our reconstructed images that there is no flow within the superior sagittal sinus. This patient happened to have a more complicated presentation. She also had multifocal parenchymal signal abnormalities and subarachnoid hemorrhage associated with these findings. Another patient, 3 weeks postpartum, with history of preeclampsia, presenting with headaches. On CT venography, although it's a bit challenging to see, you can see that there's a filling defect within the left sigmoid sinus. We also see a filling defect within the superior sagittal sinus on the coronal reconstructed image. This is our sagittal T1 weighted image, and now we're in the region of the left sigmoid sinus. And we see this intrinsic T1 hyperintensity, again, compatible with loss of the flow-related signal and clot. We can see on the T2 flare sequence that there's, as opposed to having loss of the normal flow-related signal in the right sigmoid sinus, there's signal here in the left sigmoid sinus compatible with clot, and we can see the filling defects on the post-contrast portions of the exam within the left sigmoid sinus and the superior sagittal sinus. And we can also utilize our gradient sequences. So the gradient sequences demonstrate what we call susceptibility, this loss of signal when there's hemosiderin. And we can see that nicely here, that there is susceptibility within the torcula and also within the right transverse sinus compatible with clot. Now, to detect subarachnoid and intraparenchymal hemorrhage, our non-contrast CT is first line, especially when there's an acute neurologic change. It's fast. CT angiography offers a rapid and non-invasive interrogation of the vasculature, although it is associated with, like CT venography, iodinated contrast, and radiation. However, MR angiography should be considered when appropriate, though small aneurysms may go undetected. So when would we use MR angiography? Perhaps a patient has a known aneurysm, and we want to follow to see if there's been any growth over time, which may affect planning for delivery and time to treat. And however, digital subtraction angiography is the gold standard to detect aneurysm and vascular malformation in the setting of subarachnoid and intraparenchymal hemorrhage, respectively. So here we have a pregnant woman who presented with the worst headache of life. Our non-contrast CT done in the rapid setting demonstrates scattered regions of cisternal subarachnoid hemorrhage. We see along the intrahemispheric fissure, and we can see here in the left sylvian fissure. And on our reconstructed CT angiographic images, we can see that there's a left MCA bifurcation aneurysm, so there was a ruptured aneurysm, which was the cause of her acute presentation of subarachnoid hemorrhage. Here we have a patient who, prior to pregnancy at the age 40, was diagnosed with a left posterior communicating artery aneurysm. 2 years later, it was followed on CT angiography, and there was stability of the aneurysm. However, during pregnancy with twins, 2 years after that, an MR angiography was performed, and it's demonstrated notable interval increase in size of the aneurysm. So at 35 weeks, patient was delivered via C-section, subsequently went to digital subtraction angiography, and was treated with endovascular coil embolization. Here's a 24-year-old female who presented with acute vision loss and headaches at 32 weeks pregnant. Non-contrast CT performed demonstrated an intraparenchymal hemorrhage within the left occipital lobe with some surrounding edema. After further vascular workup, patient eventually went to digital subtraction angiography. This is an injection of the vertebral artery, and it demonstrates an aberrant connection between the arterial system and the venous system with early venous drainage and this nidus here, and this was compatible with a arteriovenous malformation. Now, the risk of arterial stroke is increased around the time of delivery and the early postpartum state. There's a slew of pregnancy-related factors that could be the cause of stroke. However, what's important to note is that the neuroimaging for stroke is similar for the general population. So here we have a postpartum patient 1 week after delivery who presented with an acute left-sided weakness. Patient underwent MRI, and we see a region of restricted diffusion on our DWI sequence within the right MCA distribution compatible with acute infarct. On her MR angiography, we can see what looks like two flame-shaped regions of signal abnormality within the proximal cervical internal carotid arteries, and then we see loss of the flow. Really, we should see the cervical internal carotid arteries continue up towards the skull, and this was compatible with bilateral cervical arterial dissections, which we can see at an increased rate in the postpartum state. In terms of the entities that predominantly show parenchymal signal abnormality, so cerebrovascular manifestations of hypertensive disorders in pregnancy are a major cause of maternal death. In their earliest stages, the CT or MRI may be normal. However, when positive, the imaging findings may be identical to posterior reversible leukoencephalopathy syndrome, what people know as PRES, or also known as posterior leukoencephalopathy syndrome, RPLS. So here's a patient who presented with headaches and was diagnosed with eclampsia. And our non-contrast CT demonstrates these patchy areas of subcortical hypodensity in a posterior predominant distribution within the parietal and occipital lobes compatible with PRES. On MRI, another patient who was 38 years old and postpartum, also with headaches, demonstrated patchy subcortical predominant T2 FLAIR hyperintense signal abnormality within the posterior parietal lobes. And we also see signal abnormality within the left cerebellar hemisphere, right cerebellar hemisphere, and brainstem. And what's important to know is that classically, PRES presents with posterior distribution, predominantly parietal and occipital regions of T2 signal abnormality. However, the infratentorial hemisphere and midline structures in the supratentorial hemisphere can also be affected, and even primarily what we would call an atypical type of PRES. And here we see another patient with PRES who on the non-contrast CT, we can see that there's multifocal areas of subcortical predominant hypodensity. It's hard to see, but we see it in the right occipital lobe, and the right temporal lobe, and right frontal lobe. And on MRI, we see that their signal abnormality is evident within the bilateral thalami, and even in the left cerebellar hemisphere. Now, PRES can also have superimposed like complication, we call complicated PRES. So if there's regions of restricted diffusion, so this is our DWI sequence, which demonstrates areas of restricted diffusion which are superimposed ischemic change. Now, here we see another patient who also was diagnosed with eclampsia at 31 weeks pregnant and had also had severe headache. And on our T2 FLAIR sequences, we can see multifocal areas of subcortical predominant T2 FLAIR hyperintensity within the bilateral occipital lobes, parietal lobes, frontal lobes, and within the basal ganglia as well. And she also had a superimposed little tiny infarct compatible with a complicated PRES. However, when an MR angiography was performed, it demonstrated regions of vascular narrowing. So associated with imaging findings of PRES, either in the late pregnancy or early postpartum state, was what we call reversible vasoconstrictive syndrome or postpartum cerebral angiopathy, which is associated with vasoconstriction of medium and large size arteries. Now, however, they should resolve after some time, right? It's a reversible vasoconstrictive syndrome. And in this patient, about a week later, we see resolution of the T2 FLAIR signal abnormality. I know sometimes RCVS can also be complicated with intraparenchymal or subarachnoid hemorrhage and obviously areas of infarct. Okay, and here's a patient who also presented with eclampsia and severe headaches. And we see on the non-contrast CT that there's a focal region of hemorrhage. The T2 FLAIR MRI sequence demonstrates, again, subcortical regions of patchy T2 FLAIR hyperintensity. We see it within the left occipital lobe here, in the left temporal lobe, and also slightly within the right occipital lobe. And this was complicated by superimposed hemorrhage, as demonstrated by susceptibility on the gradient sequence. Another example of RCVS with a patient who had headache just prior to delivery and for a week after. So on her non-contrast MRI, we see subtle areas of subcortical T2 FLAIR white matter hyperintensity within the occipital lobes, parietal lobes, and creeping towards the posterior frontal lobes. Her MR angiography was negative. However, she subsequently went for digital subtraction angiography, and if you can see, there are multifocal small vessels that are narrowed, compatible with RCVS, and it looked very similar to like a CNS vasculitis. For the diagnosis to be made, typically we would require like resolution of the narrowing after that. Okay. In terms of epilepsy, so in patients with primary or known primary epilepsy, we can use established protocols during pregnancy to evaluate them, typically non-contrast. Now, there are multiple etiologies for new seizures during pregnancy, which for contrast may be beneficial, but however, it's not essential. If diagnosis can't be made, then a risk-benefit analysis should be performed. Okay, now for neoplasm. So an intracranial mass can expand or hemorrhage due to hormonal and vascular changes. So neuroimaging by MRI should be used to evaluate for focal brain or spinal cord symptoms because the treatment during pregnancy may lead to a favorable outcome. And sometimes brain imaging may be helpful prior to delivery to assess if there's hydrocephalus or increased intracranial pressure. Now here we have this is an unfortunate 18-year-old patient who prior to pregnancy was diagnosed with right ventricular ependymoma. This is our T2 flare sequence showing the signal abnormality, and this is the post-contrast sequence. And about 5 months later, at 10 weeks pregnant, she presented with neck pain and seizure activity. And now we see rapid enlargement of the mass. There's notable surrounding edema. And we see this is our gradient sequence. We see a lot of susceptibility compatible with hemorrhage. At 30 weeks, the child was delivered via emergent C-section, and post-contrast imaging was performed, which demonstrated marked progression of this mass. We see supratentorial and infratentorial progression. Here we have a patient who had, prior to pregnancy, a known parastellar meningioma. You have to trust me that it's a meningioma. And it's uplifting the optic chiasm, but was mostly asymptomatic. 22 weeks pregnant, she was presenting with visual deterioration and diplopia. And we see that her meningioma has increased in size with a progressive mass effect on the optic chiasm. Okay. Now, Wernicke's encephalopathy. So Wernicke's encephalopathy can be present in a pregnant patient who with hyperemesis gravidarium. However, the patient's symptoms may be very different than those classic symptomatology that we would see with an alcoholic or someone severely malnourished, and could be quite vague or nonspecific. MRI can be helpful to make this diagnosis and start life-saving thiamine administration. So we see, and how do we diagnose it? So here we have T2 flare sequences, which demonstrate abnormal T2 flare signal in the periaqueductal gray around the cerebral aqueduct. We also see signal abnormality along the medial thalami and mammillary bodies. This is consistent with Wernicke's encephalopathy. Now we can also see superimposed restricted diffusion as evidence on our DWI sequences and post-contrast enhancement, but this is not necessary for the diagnosis. Okay. Now, during pregnancy, the immune system is altered to prevent maternal fetal rejection, which can alter the presentation of known CNS inflammation and demyelinating disorders. However, the imaging appearance during pregnancy is just like that in the general population. And here we have a patient who, on our sagittal T2 flare sequence, we see these T2 flare hyperintensities, which are along the closal septal junction. On our axial T2 sequence, we see multiple white matter lesions within the subcortical distribution. And on our sagittal T2-weighted sequence of the cervical spine, we see multiple focal lesions within the spinal cord compatible with multiple sclerosis. Pituitary. So hormonal and physiologic changes can lead to pituitary enlargement during pregnancy. Typically, the physiologic pituitary enlargement of pregnancy is asymptomatic. There are times, however, that it can present with optic chiasmal compression and bitemporal hemianopsia, but that's rare. Now, adenomas, macroadenomas more so than microadenomas, can enlarge during pregnancy, and the question is whether or not we should be monitoring pregnant patients during pregnancy with pituitary MRI or visual field testing or blood work. And here we have a patient who had a known prolactinoma, which was involving the right side of the pituitary gland and extending into the cavernous sinus. So in her pre-pregnancy imaging, we could see this nice asymmetry, and we see that there's asymmetric enhancement, and this is what it looked like on the sagittal post-contrast T1 weighted sequence. However, during pregnancy, there was enlargement of her macroadenoma. There was further invasion into the cavernous sinus, and that's kind of nicely depicted here. And she presented with worsening visual symptoms. However, in the postpartum state, her adenoma actually decreased in size. So pituitary apoplexy, so associated with acute hemorrhage, whether within a physiologically enlarged pituitary or within an adenoma, and can be presenting with severe headache and vision changes. And here we have a pregnant patient who presented with severe retroorbital headache and visual changes. And we see that there's an enlarged pituitary gland. These regions of T1 hyperintensity, I apologize, a little bit challenging with the lights, are indicative of hemorrhage. And on our sagittal T2 weighted sequence, we see these areas of low signal intensity that's compatible with blood products. And at an adequate level, this was pituitary apoplexy. And Sheehan syndrome, so this is the result of necrosis of the pituitary gland, which can be seen in the setting of maternal hypotension or shock postpartum. And in the acute stage, it's associated with a non-hemorrhagic enlargement. However, subsequently, we can see severe atrophy of the gland, and sometimes the diagnosis isn't made until a couple weeks to months later. And here we see a patient who's postpartum with panhypopituitarism, and on our non-contrast CT, it looks like there's some CSF attenuation, almost like mass within the cella. On the axial T2 weighted sequence, we also see this CSF appearing lesion. Maybe it's a cyst, maybe it's a mass. However, we see on the sagittal T1 weighted sequence that there's really no mass effect. And this is just what we might see all the time with increased intracranial pressure. This is just an empty cella. So this is just patient had normal pituitary function during pregnancy, and after we saw that she had loss of it, compatible with the Sheehan syndrome. Now, lymphocytic hypophysitis is an autoimmune disease, most commonly in late pregnancy or the peripartum state. It does have considerable overlap with imaging of adenoma. Things like timing, symmetric enlargement of the gland, thickening and enlargement of the hypothalamic stalk, and loss of normal intrinsic T1 signal may help distinguish it from an adenoma. However, biopsy is needed for definitive diagnosis, and one of the challenges is that the pituitary stalk usually needs contrast image, like we said, which is something we prefer not to do during pregnancy. And here we have two patients with biopsy-proven lymphocytic hypophysitis. So in our patient on the top, we see this diffuse enlargement of the pituitary gland. There is homogeneous diffuse enhancement on the post-contrast sagittal T1 weighted sequence. And we also see that there's diffuse enhancement and enlargement of the pituitary stalk, and this is compatible with lymphocytic hypophysitis. And a different imaging appearance in the patient below, right? So we see that the pituitary gland just maybe looks a little bit small, nothing to write home about. However, the pituitary stalk is thickened and nodular and enlarged, and this is compatible with lymphocytic hypophysitis. So in summary, non-contrast MRI is a typical first choice in pregnancy when an imaging exam is needed and cannot be deferred until after the patient is pregnant. CT is the most available tool for initial rapid diagnosis of acute neurologic conditions and should not be withheld in urgent situations. Intravenous contrast should only be used when necessary, and the most appropriate imaging strategy can be determined by direct consultation between the referring clinician and radiologist. These are my references. Thank you.